Good afternoon and good morning to you if you are on the West Coast. My name is Jose Leon, Chief Medical Officer for the National Center for Health and Public Housing. Thank you for attending this activity, the impact of nutrition on diabetes prevention and diabetes management. This is a live activity. At this moment, our lines are muted. If you have any questions, save your questions to the end. And either you can use the chat box and type your question, or use the raise hand icon and your line will be unmuted. Before we get started, we are the National Center for Health and Public Housing, and we provide training and technical assistance to community health centers close to public housing developments. We are funded by HRSA to provide the TTA services to health centers. In regards to public housing residents, there are around 2.2 million residents living in public housing. 59% of them are female, 52% are white, 43% are African American, and there are some numbers that are quite interesting, like 38% of the households report someone with a disability, and over 83% of them are below the federal poverty line, and 55% have less than a high school diploma. In regards to diabetes in health centers, this is the most recent information that is in the uniform data system from HRSA. Around 9% of all patients being served by health centers have diabetes. And when you compared all health centers with public housing primary care grantees, or those health centers serving public housing residents, the percentage is 15%. Out of 15%, almost 33% have an A1C greater than 9. So there is a great need of providing diabetes services and improving the diabetes services to those living in public housing. This information is from HUD. There is a publication that is a HUD CDC publication. And basically what they did was that they use HUD data and data taken from the National Center for Health Statistics to review the health of those receiving assistance from HUD. And as you can see here, most of those receiving assistance from HUD are more likely to be obese, have a disability, diabetes, COPD, and asthma. It's the same with those smoking in public housing and HUD-assisted housing. Over 33% of those living in public housing are current smokers. So I am very pleased to introduce two great speakers for today's webinar. First, we are going to hear from Shamira Robinson. Shamira serves as the Director of Nutrition at the American Diabetes Association. Prior to her current role, Shamira used a patient-centered approach to counsel, educate, and deliver medical nutrition therapy as an outpatient dietitian. She assisted with the development of ongoing evidence-based nutrition education programs and resources for patients, family, and care providers, accounting for cultural, religious, physical, and age-related needs. Her experiences in the clinical setting allow her to bring a fresh perspective and an unwavering passion to improve the lives of those affected by diabetes. Then we're going to hear from Joe Mandelson, and Joe is a registered dietitian nutritionist at and the Associate Director of Nutrition at the American Diabetes Association. She graduated from James Madison University in 2016 with a master's in nutrition and physical activity, and completed her dietetic internship at Virginia Tech the following year. Prior to ADA, Joe provided nutrition counseling at a pediatric clinic that serves the underserved community in Arlington, Virginia. In her spare time, Jo enjoys reading, cooking, and spending quality time with her 2-year-old and husband. Well, without further ado, I will turn it over to Shamira. Good afternoon, Shamira.
Good afternoon, and thank you so much for having me.
Thank you for accepting the invitation.
So we are very excited to be here and
make you the presenter, Shamira.
okay, sounds good. All right, is everyone able to see my screen? If so, you can just pop a yes in the chat box and we will keep this as interactive as we can for a webinar format. All right, I got a yes, so we are going to keep rolling. Thank you for that. Okay, so today we are going to be talking through nutrition recommendations for those living with diabetes. And more specifically, we're going to go through some of the recommendation from ADA's most recent nutrition consensus report. All right, well, thank you for that lovely introduction. Again, my name is Shamira Robinson. I currently serve as the Director of Nutrition at the American Diabetes Association, and I am joined by my wonderful colleague.
Hello, everyone. My name is Jo Mandelson, and I am the Associate Director of Nutrition at ADA.
All right, and before we jump into all of our content for today, I want to start by walking us through the objectives for this webinar. So some things we really want you to be able to walk away with are understanding of a few of the misconceptions that are out there related to nutrition recommendations for diabetes, and also understand the macronutrient needs of those living with diabetes. We also aim to explain some of the major changes that you'll see in the nutrition guidance from ADA and give you some practical tools so that you can use that evidence and use those recommendations in your clinical practice. And we also want to end by just providing a few key resources as well as guidance that you can use when you are educating your patients who have diabetes. Okay, jumping right in, navigating the headlines. When it comes to nutrition, it is such a buzzworthy topic. There are so many different beliefs and claims, and food is so personal. So everyone has that thing that works for them. And so we just see so much mixed information, so much misinformation in the media, so many different headlines, and it can be hard to understand what is the truth, where does the evidence lie, and what recommendations you should be passing forward when you're working with your patients. So for that, ADA comes together and compiles a nutrition consensus report. And the aim of this is really to look at the evidence and see what that says when it comes to nutrition recommendations. See what that says when it comes to things like macronutrients, which we'll get into later, eating patterns, all these different things, taking a look through those studies to really get some conclusive answers. So how are the recommendations developed? So every 5 years, we convene a committee of experts to review the latest research. So in that, the recommendation or the consensus report prior to the one published last year was published in 2013. And we selected a new committee of experts. It was an open call, so people could apply and we reviewed those applications. And in that, we selected this committee who went through all of the articles that were published from January 1st of 2014 all the way through February of 2018. And the articles really ranged, but we wanted to focus on people with type 1 diabetes, people with type 2 diabetes, and also pre-diabetes, which was new for this consensus report. In addition to that, we factored in things like sample size, retention rate. And once we really worked through all of those things, there were over 300 references included in this consensus report. So it is jam-packed with information, and we won't be able to cover all of it today, but we do have the link for you all to go back and to read through those recommendations in detail. Okay, so diving in, what can I eat? When you're working with people in your community, how many times have you heard this question? Or how many times have you asked this question? This is actually the #1 question we get to our Center for Information at ADA, is what can I eat? And people really looking to understand this and wanting to know where to begin when it comes to nutrition. And so the answer that we found in one of our consensus recommendations is medical nutrition therapy. That really is the starting place and the place to begin when you have someone with diabetes looking for nutrition guidance, and specifically individualized diabetes-focused medical nutrition therapy. And this benefit is so important. Not only is it covered, only is it covered by Medicare, so it's one reason to take advantage of it, but it's impactful at different stages. So I know it's commonly thought of, okay, once someone is initially diagnosed with diabetes, that would be a great time to refer them for MNT or refer them to a dietitian. However, it is also just as helpful throughout the lifespan, because as time goes on, things change, circumstances change, and that also leads us to, it's also important during times of changing health status to achieve treatment goals. So really throughout the lifespan, once things are changing, once health needs have changed, once circumstances and personal things have changed, those are all good times to think about referring to MNT, even if it's just for a refresher. Now, why is it something that's important, and why is it important to the extent that it was included in the nutrition consensus report as really a key to nutrition management in diabetes? Well, it's because really using healthful eating patterns, using nutrients and different foods is helpful in improving A1C, blood pressure, cholesterol, helping to achieve any body weight goals or targets that are set, and it can delay and prevent diabetes complications. In addition to that, what makes this a critical component of care is that in that visit, while that patient is sitting with the dietitian, that dietitian has time, and that is of the essence. And a lot of times as healthcare providers, you may not always have that time to really sit with and assess all of the needs related to food with that person. But the dietitian is able to do that. They're able to assess any personal or cultural preferences, and those things have such a significant impact on our food choices. They're able to assess what food options the person has access to. So what you would recommend for someone who may be able to take advantage of, let's say, the Double Bucks program at a farmer's market would be very different from what you could recommend to someone who only has the luxury of shopping at their local convenience store. Those food options are very different, and so how you would work with them to make food choices is also very different. The dietitian also has the ability to assess any other barriers to change, whether it be cost or preferences, like some of the things that we mentioned, and work to provide practical tools based on what the person has access to really promote behavior change. Now, talking about cost effectiveness as well as just general effectiveness for MNT. So the great thing about it, again, this is a Medicare covered benefit, but you see, based on the evidence, just as much reduction in A1C as you would see with some medication treatments. So in the research reviewed for the nutrition consensus report, it was found that MNT interventions provided by a registered dietitian nutritionist improved A1C with an absolute decrease of up to 2% in people with type 2 diabetes, and up to 1.9% in someone with type 1 diabetes. And so those are really impressive numbers, and even more reason for you to not only refer to medical nutrition therapy and refer to a dietitian, but also champion that within your healthcare system. Okay, getting to some more of the good stuff, macronutrients. So how often have you had someone ask you, okay, well, how much fat is too much fat? Or how much protein can I have? Or how many carbs should I be eating at every meal? I think these are such important questions, and the Nutrition Consensus Report really aimed to review the evidence and answer those questions. And the report revealed that there is no ideal percentage, and we wish there was a cut and dry answer so that we could just provide that information. However, there's no ideal percentage because it's so individualized. What may be an ideal percentage for one person looks very different from what might be ideal from someone else. It also depends on their eating patterns, it depends on their metabolic goals, and it depends on just their overall circumstances. Again, going back to the things they have access to, the things that they can afford, the things that they prefer. All those things have an impact. And so in understanding that, the consensus committee went back to the table and said, you know what? Okay, there's no ideal percentage of calories from macronutrients. But also, when we're thinking about food, people don't eat macronutrients. They eat meals, they eat food. And so we went a step further to review different eating patterns. So here's a list of the different eating patterns that were reviewed within the Nutrition Consensus Report. We took a look at the Mediterranean style eating pattern, vegetarian and vegan, low fat, the low fat Ornish or Pritikin, low carb and very low carb, DASH, intermittent fasting, and paleo. In reviewing studies for these, it all boiled down to a few key points that we're going to share with you here today. One, when it comes to type 1 diabetes, there's no eating pattern that has robust evidence there. There were some studies that showed preliminary evidence for low carb eating patterns, but again, that wasn't substantial. For type 2 diabetes, we saw the most evidence for improvement with low carb eating patterns as well as Mediterranean style eating patterns. Now, low carb, I know this gets quite a bit of traction. And so what was new in this consensus report is that there were recommendations that came out actually stating that reducing overall carbohydrate content or intake has the most evidence for improving glycemia. And this is something that is significant because we know that carbohydrates, once they break down, have the most impact on blood glucose levels, but also thinking about it in terms of eating patterns. So you hear low carb, and a lot of times it's associated with a very specific eating pattern. However, this is something that can be applied across eating patterns. So if someone is following a Mediterranean style of eating, they could also work to reduce their carbohydrate intake and still see those benefits. Another recommendation that came out of the consensus report is that low and very low carbohydrate eating plans are viable approaches for select adults with type 2 diabetes who are not currently meeting their glycemic targets and wish to reduce their anti-glycemic medications. Now, I know you might be thinking, okay, well, who wouldn't want to meet their targets and who wouldn't want to reduce their medications? But again, this is a matter of working with that person, having a patient-centered approach to really understand what their needs are and what barriers they may be facing. So someone who has certain food preferences, it may not be the best approach for them to explore a low carb or very low carb eating pattern, since there is a lot of restriction that goes into place when we're talking about those sorts of eating patterns. Again, the low carb and very low carb eating pattern can also be protein forward or include a lot of different sources of protein, which can be more expensive for some people who may not be used to eating in that way. So if cost is a consideration, it may not be the approach that's best for that person. There are also certain pre-existing conditions that are contraindicated when we're thinking about low carb and very low carb approaches, and those include chronic kidney disease, pregnancy, and disordered eating. So if you are concerned about those things when you're working with someone, or they have a history of those things, then that's another time where prioritizing a low carb or a very low carb eating plan may not be the best approach. So we're sharing this helpful resource here and going back to that idea that no matter your eating style, your eating plan or pattern, there's ways to reduce that carbohydrate intake if that person is not currently meeting their glycemic targets to possibly see some improvement. And it doesn't have to be an all or nothing. It can really be an incremental approach. So looking at this graph that we see here, that highlighted area, that between 40 and 50%, that's where most people living with diabetes are typically at when it comes to their daily intake of carbohydrates. So you can see it's segmented by total calorie range. So for someone who's following a 1,500 calorie diet or eating plan, if they're currently eating 40% of their calories from carbohydrate, that's about 150 grams there. So if you notice that person isn't quite meeting their targets, a potential place to start is just saying, okay, well, how can we reduce that? What if we go down 10% to that 113 grams and see what happens to those blood glucose levels when we make that sort of change? So that's not implementing severe restrictions. That's not completely changing the way a person is eating. That's not asking them to go out and find foods they may not have access to. That's just making small changes that can be in terms of portion size, food selection, that could possibly result in some benefits to the blood glucose levels. And here we have a chart, which is in the nutrition consensus report, but summing up all of the different eating patterns that we looked at. So you can see which ones had effect, a beneficial effect or a significant effect when it comes to lowering A1C, when it comes to reducing the risk of cardiovascular disease, reducing weight, reducing LDL and blood pressure. And so this is just a handy chart to really get a quick look at the effectiveness for each of those different eating patterns. And so we reviewed all these studies, we reviewed all of this information, and the bottom line comes to evidence does not support a clear preference for a specific eating pattern. So again, it's individualized, and you'll hear us say this a lot, and I know, it doesn't make it any easier for you when you want to provide quick guidance, but when we want someone to really be invested and to follow a plan that's going to make a difference for them, it really just has to include the things that are most important and relevant and the things that they prioritize, which can only be accomplished through individualizing that approach and individualizing that plan. However, hope is not lost. So yes, there's no clear eating pattern that you can refer to, but the committee did find 3 key areas that were common across all of those different eating patterns. And as a healthcare provider and a practitioner, there are these 3 areas that you can really focus on when you're looking to provide quick guidance when you're working with your patients with diabetes. And with that, I am going to pass control over to Jo so that she can pick up with the presentation.
Thank you so much, Shamira. So just bear with me, everybody, while I go ahead and pick up. So if you can give me a thumbs up or a yes on if you can see my screen, I'll go ahead and start. All right, I think that's a yes. So I'm going to go ahead and proceed. So as Shamira mentioned, there are a lot of eating patterns that people with diabetes can choose to follow if they want to start making impactful changes to their health. But obviously there's several factors to consider here. What does this mean as a practitioner? How do you counsel these types of patients? And the first things first is you want to start small, because like I said, there's considerations. Are they ready to change? Do they have the ability to change? There's socioeconomic factors, there's cultural factors, and really providing someone with a full 180 change to their eating habits is likely just not going to be sustainable for them. So you want to meet them where they are and individualize their goals. Okay, sorry, it froze for a second. Okay, so if you take nothing else from our presentation, these are the 3 key takeaways. So I think the consensus report does a really great job of talking about the eating patterns and different options and the macronutrients and comorbidities. And there's a ton of information out there. So if you haven't had a chance, I really encourage you to download that document and read it and take a look at it. But these are the 3 main takeaways. And this is really just the main points of all of the eating patterns. So this is the common themes that we see across the eating patterns. And it's not only for people with diabetes, this really can have an impact on all patients looking to eat healthier. So the 3 main things are going to be emphasizing those non-starchy vegetables, minimizing added sugars and refined grains, and choosing whole foods over highly processed foods whenever possible. So I'm just going to go through these quickly. So emphasizing non-starchy vegetables, that's exactly what it sounds like. The recommendation that we usually give people is to make half of their plate, a 9-inch plate, a non-starchy vegetable. And I think one of the main questions that we get asked as dietitians is, are canned and frozen options okay options for me to be eating? And the answer is yes, absolutely. We definitely want to see people eating that if that's what's available to them, if that's what they prefer, if they're looking for longer shelf life, especially these days where grocery shopping isn't quite as easy. Canned and frozen are great options. What you want to talk to your patients and your clients about here is that you want to look for low sodium or no added salt in the canned options. And when you're looking at frozen, you want to check out the ingredient list and make sure there's no added sauces. Sometimes those sauces can add butter and salt or other ingredients that you don't really want to add to your food. So just it gives people the ability to season the food themselves. So minimizing added sugars and refined grains. We know that there's a lot of added sugar in some food and beverages. So pointing out these sources might be important to some people. Some people don't realize that a coffee beverage has a lot of added sugar. So maybe even just showing them on the nutrition label, hey, this is where you can find the added sugar in this food. And you want to look for little to no added sugar in the majority of the food that you're eating. But again, this is meeting people where they are. If someone is eating white rice, for example, jumping right to brown rice might be a really big ask for them, especially when you talk about a lot of cultures in the world use white rice as a base, and it's the main part of their dish. So talking to them about, well, could we reduce the portion? Could we start with reducing the portion of white rice? Or could we maybe make it half brown rice, half white rice? That way they're getting that additional fiber in the meal. That's really what we're looking for when we're talking about the whole grains and refined grains, is getting that additional fiber. And that's actually a great segue to my next slide. Choosing whole foods over processed foods whenever possible. And this is going to have major benefits, not just with that fiber that we were talking about, but there's also increased vitamins and minerals when you're choosing whole foods. We know that regular intake of fiber is associated with a lower all-cause mortality in people with diabetes. And there's also research indicating that a modest reduction, an increase in fiber is going to have a modest reduction in A1C. So the sources of fiber we're looking at here are going to be vegetables, legumes, lentils, beans, pulses, fruits, whole intact grains. So I talked about that brown rice. It's not just brown rice, it could be quinoa or whole grain wheat. Any of those products are really going to have an increased fiber intake for an individual. Now we've talked about the food a little bit. Now let's talk about the individual as a whole. When we're talking to people, we don't live in bubbles, right? So we're not just talking about diabetes. Sometimes we're also talking about other comorbidities and other risk factors along with diabetes. So we want to consider the person as a whole. With overweight and obesity, there are multiple risk factors. This is one of the common ones that we see. So if this applies to your patient, because keep in mind, diabetes isn't a one-fit-all. This might not apply to all type 2 patients. Not all patients need to lose weight, but if this applies to your patient, there's research that shows that even a modest weight loss of 5% can have clinical benefits on things like A1C, cardiovascular disease risk factors, and quality of life. The diabetes prevention program model is solely based on 7 to 10% initial weight loss in patients with prediabetes, and that's to prevent or delay the onset of type 2. And if it's safe and feasible, a goal of 15% might be appropriate for optimal outcomes. And this is just kind of reiterating that point about prediabetes. With type 1 diabetes, like I said, it really just depends on the patient and the person you're talking to. Weight loss might not be recommended, but there might be cases where it is. So just having that individualized approach is going to be important. So something else that you might need to address with an individual is diabetes and cardiovascular disease tend to go hand in hand. A lot of the recommendations that we discussed in the key takeaways really apply to all of the eating patterns that Shamira was mentioning, so DASH and Mediterranean diet. But here's some additional points that you might be interested in sharing with an individual. So you might want to review sources of saturated fat, so things like red meat, butter, lard, etc., and really encourage a reduction there. Cutting back on salt and sodium, showing them on the nutrition label where that might be located. Increasing physical activity. This is a really big one, especially this day and age. So if you're doing telehealth, talking to an individual about how they can stay active in the home, or if possible with social distancing, going out and walking a little bit might really have an impact, and it's going to be really important. Increasing fatty fish has been shown to have cardioprotective benefits with increased omega-3s. And then this last one is a little bit trickier, but cutting back on some of the carbs. Shamira touched on some of this, but this also goes back to that recommendation. It can be as small as going back to that recommendation of reducing starchy vegetables and increasing those non-starchy vegetables. So with chronic kidney disease, it's often thought, it was thought before previously that you needed to reduce protein for someone that has chronic kidney disease, but the evidence is actually showing that reducing protein could actually lead to some malnutrition. So in most cases, you actually just want to keep the protein recommendation the same as an individual with diabetes or a regular individual, and not really adjust for those. So these are just kind of the specific recommendations for protein. And food insecurity and access to healthy food. This is kind of a big one. We know that this is going to have a major impact on how often someone is eating and the types of food that they're eating. The odds of having diabetes are almost twice as high among low-income adults who are food insecure compared to low-income adults who are food secure. So this is an especially tricky topic this day and age. We talked a little bit about the frozen food and canned food options and stable foods, but if you're not already doing this, you want to make sure that you're screening individuals to make sure that they have access to food. There are the 2 vital hunger screening questions that you can use, and then if someone screens positive, you want to consider tailoring your conversation to meet their needs. This could be providing them with resources, having those resources available, things like SNAP, WIC, school meals, food banks. Unemployment benefits are important these days, and then maybe other specific resources available in your community that might not be available nationwide. So having those readily available to share with them, that might be the entire appointment itself, just getting them access to food, or even just talking to them about budget-friendly food options. And I am going to go ahead and pass it back to Shamira.
All right, thanks for that, Joe. Now, before we conclude, again, we've talked through a few of the recommendations from ADA's most recent nutrition consensus report, but we want you to know that there is so much more information in that report, and we want to share with you some of the other topics that are covered. So alcohol is covered and what those recommendations look like for someone living with diabetes. We talked through sweeteners, energy balance, and weight management, MNT as it relates to medications, micronutrients, gastroparesis, insulin dosing and meal timing, as well as personalized nutrition. So those are all some of the things that we really take a deeper dive into within the consensus report itself. You can advance to the next slide, Joe.
I'm actually having a hard time. Let me see. Oh, there we go.
There we go. Okay. And we also wanted to leave you with some resources that you can use. So each of the links you see here are hyperlinks, so you can click through to access a lot of these ADA resources. But to talk through some of the things on this page here, we have our Ask the Experts Q&A series, and this is great because each month it's like a town hall or a broadcast. We like to call it our little radio show, but we cover a new topic related to living with diabetes, type 2 diabetes specifically. And we do a dial out. So once you register, we either call your phone or you can call in or stream online to be a part of the event. But different topics include, I know most recently we had a grocery shopping Ask the Expert series where we had a dietitian who works for a local grocer to come in and really talk through what that looks like. Our last event was getting motivated to get moving. So we covered physical activity and how you can still stay active within the home. And so it's just a great event, especially as most of us are under stay-at-home orders, to have an expert, have access to an expert, and all of the callers on the line are able to come on. We select callers and they ask their questions live. So it's a really great resource to provide people where they can get their questions answered live from experts without having to leave their homes. So that's available there. We have a link to the nutrition consensus report as we walk through today. We also have a link to our Living with Type 2 Diabetes program, which is a wonderful resource, especially for those newly diagnosed with type 2 diabetes. And it provides information for them, just general things with stress management, emotional health, physical health, walking through a lot of those things. But you also get a free subscription to our Diabetes Forecast magazine. So once someone is signed up for that program, they also get a subscription to Diabetes Forecast for a year, as well as just e-booklets that they can go through and walk through a lot of information that might be helpful for them on their journey. We have our diabetes and coronavirus page linked here. So ADA has been doing a lot to stay on top of COVID-19 and offer as many resources as we can, whether that's related to help with insulin or just guidelines and practices, best practices. So that's a link that you can go to. It's constantly being updated. So we've shared that here so that you can access that at your leisure. Diabetes Food Hub is our new recipe website. And so this website has a ton of recipes for people looking for what to eat or what to make when managing their diabetes. All of the recipes on Diabetes Food Hub have been reviewed and approved by the nutrition team at ADA, so you can feel safe offering this as a resource for people looking for things to cook. And it's also a very timely resource because as a lot of us are in our homes more often, we are also looking for things to make. You know, not as many places are open. And so we've worked to make resources available on Diabetes Food Hub as well, and things related directly to COVID-19. So there is an entire meal section just dedicated to pantry staples and easy recipes you can make, thinking about things that you may have around the house. We have our diabetes plate method placemat, and so that is one of our handouts that is very handy. You see a picture of it there on the top left-hand side of the pictures, but it goes through those portions that Joe discussed when she was walking through emphasizing non-starchy vegetables. It talks about what those portions look like. It talks about different foods that can go in each of those sections, and on the back of that placemat, there's actually information about how to measure out portion sizes using your hand, for instance, what things you should look for when it comes to healthy fat sources and how to add those in as well. So that is a very comprehensive tool offered by ADA. We have the large laminated 11 by 17 available for purchase on our Shop Diabetes website, but there's also an 8.5 by 11 handout that can be downloaded in our patient education library. So if you're a professional member with ADA, then you can just go and download that from the education library and print that off to use in practice. So lastly, I also want to make mention of our ERPs, so our recognition programs. So if you're looking to find out more about DSMES and how you can offer diabetes self-management education and support, that is a wonderful resource to learn more. I know there's a lot going on with trying to transition programs to a virtual or telehealth option. And so that's a good way to find out if you don't have access to that, if it's something you're looking to start, or if you're finding out how you can transition your existing program, you can find helpful information there. And lastly, just our Center for Information. So everything that we have going on, you can always call that Center for Information number, that 1-800-DIABETES, and either ask for information. You can provide that number to your patients and they can call and ask for information. And there will always be an answer, or they'll always record that question and get back to them with a resource, with an answer, all of that information. So I know that might be resource overload, but we wanted to put all of those things in one place. And I think everyone will be able to get a copy of the slides. And so you can just click through and access any of those ADA resources at your leisure. All right, so that concludes the presentation and we are open for questions.
Thank you so much, Shamira and Joe, for this outstanding presentation. Thank you for your support to the Health Center program. And thank you for all the current information that you have provided. And as Shamira said, with the slides will be sent to all participants after the webinar is over. So you will have access to the recording and you will have access to the slides and the resources that were shared by Shamira. So before we get to the Q&A session, I just want to ask those participating to please complete the post survey. Your feedback is really important and it helps us to improve our sessions and our webinars on training and technical assistance. So once again, if you would like to ask a question, you can either use the chat box and you can type your question, or if you would like to ask your question to the panelists, please use the raise hand icon and your line will be unmuted.
Hi, Dr. Leon. So we do have one question. This question is from Delianas. Have the physical activity recommendations changed?
So the physical activity recommendations, well, physical activity was not covered in the nutrition consensus report. However, the most recent physical activity recommendations can be found in the standards of care. So I don't believe that they've changed much. I'm not sure the most recent version that you've seen. So I don't believe they've changed much from the 2019 recommendations, but the 2020 recommendations are available in the updated standards of care. And if you would like the link to that, I am happy to share that with you, as well as to share that we now have a living standards as well. So as the latest and breaking in research comes out, they're actually making living updates to the standards of care to be incorporated throughout the year. So I am happy to share that with you if you do not already have that link.
Thank you, Shamira. And before we get another question, I just want to mention something that Joe shared with us, and is the food desert issue. Health centers, specifically those located in or immediately accessible to public housing, are considered food deserts. They have different strategies to address the needs of patients with diabetes. They have the food pantries. They have some partnership with farmers market just to provide a healthy food to those living in public housing. But that is a great issue. And the other concern in these communities is that some of these communities experience violence, community violence, which makes patients very difficult to exercise and to go outdoors. So they have some exercise and nutrition programs that they have basically inside of the health centers or on the health centers properties, just to make sure that patients have access to exercise and healthy food. So that is just a comment, and it was very timely, and it was very well said by Joe.
And I thank you for that comment, because I mean it's so relevant, especially as we're working with people. Yes, a lot of times as providers, the focus is how can I help to, manage the condition or help this person meet their health goals, but there's so many other factors that can be going on and that can be contributing. And so even from a nutrition perspective, yes, we may notice maybe someone is, not consuming enough of those non-starchy vegetables that we talked about, but that might not be the place to start when it comes to recommendations. If that person is worried about violence in their community, if they're worried about how they're going to pay their rent this month, or if they're worried about, how they're going to feed their children, talking about getting more broccoli is not always the most effective strategy, but really assessing where they are, meeting them where they are, and figuring out what the priorities are for them in that moment, and helping them to get to that point. So then eventually we can start to get to some of those, recommendations that help them to get closer to those health goals. So thank you for sharing that comment.
Thank you. Fide, any questions in the queue?
Yes, we have one more.
Okay.
This is a question from Claudia, and it says, what is the best way for participants to record and report their carbohydrate intake?
So I think there's a few different strategies. If they have access to a phone and they can download apps, there are a lot of apps out there that can help with tracking their intake and keeping it, helping them to keep a log of the carbohydrates that they're eating. If you have someone that might be a little more old school and they prefer pen and paper, there are also ways to just use food labels to look at the carbohydrates in the different foods that they're consuming and keep track of that manually in a notebook. There are also resources like exchange lists in the Choose Your Foods book by ADA, where it walks through different foods and how much of that food equals to how many grams of carbohydrates. So really to help think through those portion sizes and what that equals to in terms of grams of carbohydrate. And there's websites as well that can help with gauging that. If you refer someone to whether it be diabetes education or medical nutrition therapy, a lot of times that dietitian or that certified diabetes care and education specialist is equipped to do a food recall with the patient to see what a normal day looks like for them and add up just mentally most of the time about how many or estimate about how many grams of carbohydrate that person is having. But the best way and the easiest way, again, if they have access to a phone, there are several apps that can help with that. And if they don't have access to a phone or they prefer to do things manually, if they just keep track of the things that they're eating, keep a food log, then they can go back and find the information they need to fill out, okay, how many grams were in that slice of bread I had? How many grams of carbohydrate were in that cup of rice that I had? And just doing that is very helpful. And it's helpful if they're checking their blood sugar because they can look and compare, okay, well, I had this today and I saw this change with my numbers, and it fine-tunes that process for them as well.
Excellent. Thank you so much for that response. Any other questions, Piri?
Not at the moment.
Okay, I just have a question while we wait for another question. Is there any recommendation on I'm looking this from a provider perspective. Sometimes when you have patients who are vegan, even though they are consuming the right amount of carbohydrates and proteins and fat, due to the diet, they have to sometimes rely on shakes, you know, to add additional protein to their diet. Is there any recommendation from ADA on any of these shakes or protein supplements?
So within the consensus report, we do talk about meal replacement shakes and how for some, especially if you're working with someone who has overweight or obesity, that meal replacement shakes can be a good option. Now, we don't make recommendations or endorse a specific product, but in cases where you've tried medical nutrition therapy, you've tried diabetes education, you've tried making changes, those lifestyle changes, so the physical activity and changing up the eating patterns, and even in some cases switching up the medications, and you're not seeing a lot of impact there, then those meal replacement shakes can be an option to explore. And in the consensus report, it also touches on weight loss surgery, and so when that could be an option to explore as well, in addition to intensive programs, weight loss programs.
Excellent. Thank you, Shamira, for the response. Any questions, Pire, in the queue?
Yes, we have one more
Okay.
from Kate, and she says, how do you motivate patients who are not yet in preparation or action stage of change?
I think that is a great question. And if we had the answer to that, we would all be smooth sailing. I think a part of our job as healthcare providers is to understand when we can motivate and when the person is just not there and why. And so assessing their readiness to change. If you have someone and they are just not interested at all in making any of those lifestyle changes. I think one thing that I typically did when I was practicing in an outpatient setting was seeing what I could find out as far as why they were resistant to making that change. Now, sometimes they would share that information and sometimes it would be personal. But when I found out the why, it made it easier to provide some sort of motivation. But in some cases, that why is it's not a priority, whether it be they have more pressing things that are on their mind, whether, they're worried about, like I mentioned earlier, okay, well, I'm trying to figure out how I'm going to pay my rent and keep a roof over my family's head. So talking about how to make these lifestyle changes is just not a priority for me in this moment. And in cases like that, as providers, there's not much that we can do to get them motivated if they aren't motivated themselves. But what you can always do is share the potential benefits. You can share some different resources and strategies and hope that when they're in a place, if they get to that place where they are motivated to make those changes, that they'll revisit some of those things.
Thanks, Shamira. And I would like to add that sometimes there is a need of providing motivation, what is called motivational interviewing. And there are some resources, and if I'm not mistaken, the American Diabetes Association has some resources on motivational interviewing.
Mm-hmm.
And we have done some activities as well, so you can find additional information on our website. But that is a topic that is currently being explored by different organizations, federal and non-profit organizations, on how to keep your diabetic patients motivated. Any questions today?
Yes, so we have one other question from Aisha. Aisha, I'm gonna go ahead and unmute you.
Hi, good afternoon, you guys. I work for FQHC and we serve a large portion of the homeless population. What recommendations do you have in terms of engaging or outreaching to the homeless population to provide care, not only care for diabetes, but also education assistance?
So that is a really good question. And I am not sure of any resources that the ADA has specific to that population, but I think that's a really good question. And if you could drop your email for me in the chat box, then I will take that back to the larger team and see what work we've done specific to that population and share that back with you. But I think that's a great question, and I want to make sure I'm giving you that most accurate information that we have as ADA. So yes, give me your email and I will get back to you with that.
That's excellent. Thank you, Shamira. In the, if I'm not mistaken, it's the first or second chapter of the standards of care. There is new information, but for special vulnerable populations. There is some information regarding public housing, residents and migrant and agricultural workers. I don't remember seeing anything on the homeless, but that is a great question. And if you can send that question, I will be happy here to send it to Shamira and Joe. But in the meantime, there is another organization, and this is the National Healthcare for the Homeless Council, and they have excellent resources and recommendations for homeless patients. I'm not sure if you are familiar with them, but they do have information on diabetes and how to address any chronic medical conditions affecting people experiencing homelessness. Any other questions, Kitty?
No, not at this time. And thank you so much, Aisha, for that question.
All right, thank you so much for this. Again, I would like to thank Shamira and Joe for these great presentations, and everybody who took time out of their busy schedule to participate today. You can also, well, you can visit our website. You can find additional information on upcoming activities. You can also find information on webinars and monographs and other publications that we have on the website, all these related to public housing, primary care. And you can also contact any of our staff members if you have any additional questions. So with this, we conclude this activity. I would like to thank again our presenters and all the participants for the opportunity. Thank you and have a great afternoon.